Welcome to Module 4, Self-Monitoring Blood Glucose, A1C, and Continuous Glucose Monitoring. I hope you enjoy this section of the course. Please let me know via email or discussion board if you have questions about content. If you are having problems viewing or hearing the presentation, please contact the program administrator. Discussion topics for this course include primary methods of evaluating control, glucose and A1C target goals, benefits and frequency of self-monitoring blood glucose and A1C, postprandial glucose testing, limitations of A1C, glucose monitoring in specific populations, evaluation and teaching, and continuous glucose monitoring. Target A1C and glucose goals should be individualized based on a patient's duration of diabetes, age, life expectancy, comorbid conditions, known cardiovascular disease, or advanced microvascular complications, unawareness of hypoglycemia, and other considerations. Lowering A1C to below or around 7% has been shown to reduce microvascular complications of diabetes, and if implemented soon after the diagnosis of diabetes, is associated with long-term reduction in macrovascular disease. Therefore, a reasonable A1C goal for many non-pregnant adults is less than 7%. The Diabetes Control and Complications trial showed that improved glycemic control is associated with significantly decreased rates of microvascular and neuropathic complications. Goals for bedtime may be needed, especially for those at higher risk of nocturnal hypoglycemia, such as patients with type 1 diabetes, or those with type 2 diabetes receiving insulin therapy, young children, and the elderly. Blood glucose goals should also occur for postprandial hyperglycemia. Postprandial hyperglycemia has a greater contribution in A1C levels closer to 7%. If pre-meal glucose values are within target, but A1C values are above target, recommend testing the blood sugar before and 1 to 2 hours after meals, with a postprandial glucose goal of less than 180 milligrams per deciliter. Self-monitoring blood glucose has many benefits. Major clinical trials assessing the impact of glycemic control on diabetes complications have included self-monitoring blood glucose as a component of effective therapy. There is a correlation between self-monitoring blood glucose frequency and lower A1C. Several diabetes management strategies reliant on self-monitoring blood glucose testing have demonstrated improved glucose control in patients. Self-monitoring blood glucose allows patients to evaluate their individual response to therapy and assess whether glucose targets are being achieved. Results of blood glucose monitoring can be useful in preventing hypoglycemia and adjusting medications, medical nutrition therapy, and physical activity. Because the accuracy of monitoring blood glucose is instrumental and user-dependent, it is important for healthcare clinicians to evaluate each patient's monitoring technique and accuracy of equipment. In addition, optimal use of self-monitoring blood glucose requires proper interpretation of the data. Patients should be taught how to use the data to adjust food intake, exercise, or pharmacologic therapy to achieve specific glycemic goals. By using self-monitoring of blood glucose, a more accurate picture of the patient's glucose patterns can be obtained when he or she is involved in a usual daily routine. To provide data about glucose patterns that can be used by the healthcare team working with the patient to make treatment decisions. It can also be used to provide data with which patients themselves can make daily decisions on treatment adjustments, and to provide feedback on how effectively the individual is adhering to daily self-care routines, including medical nutrition therapy, physical activity, and medication use. Until the last couple of years, all blood glucose meters read the glucose level in the blood sample as whole blood. Then several years ago, a meter was calibrated to read the blood glucose sample as if it were plasma. Because the results of blood samples taken from your vein at your doctor's office or lab are reported as plasma, by having the meter record results as plasma glucose, it became easier to compare lab tests with blood glucose meter results. Today, most newer meters provide blood glucose readings as plasma glucose readings. The difference is that plasma numbers read about 10 to 12% higher than the older whole blood numbers. So, if the fasting and pre-meal blood glucose target is 90 to 130 plasma, it would be 80 to 120 if the meter reads whole blood. It's important to know if the meter reads plasma or whole blood and then what targets to use. Advise the patient to check their instruction manual. Contact the manufacturer of the meter by using the 800 number on the back, or ask a diabetes educator if they need assistance. The frequency and timing of self-monitoring blood glucose should be dictated by the particular needs and goals of the individual patient. Patients with type 1 or type 2 diabetes on insulin typically need to perform blood glucose monitoring more frequently than those not using insulin, particularly if using glucose readings to guide mealtime insulin dosing. It is recommended that patients using multiple insulin injections perform blood glucose monitoring 3 or more times per day. For people who are testing 1 to 2 times a day, if left to their own devices, tend to check their blood at the same times each day, providing the same repeated information day after day. Instead, they should be encouraged to vary the times that they test among those times that provide useful monitoring information. Usually, before meals and bedtime are the most commonly recommended times from which to choose checking times. However, occasionally such patients should be encouraged to perform their daily quotient of checks before and after a given meal to get a sense for the postprandial glucose excursion. Obtaining readings 2 hours postprandially is useful as postprandial hyperglycemia has been implicated in increased macrovascular risk. Postprandial checking is useful for patients whose A1C is elevated but fasting glucose is on target, for patients who are using glucose-lowering agents targeted as postprandial glucose, such as the short-acting secretagogues, or the incretin mimetics, and as an evaluation tool for patients who are making dietary and physical activity changes. The optimal frequency and timing of glucose monitoring for patients with type 2 diabetes on oral agent therapy are not known, but should be sufficient to facilitate reaching glucose goals. Monitoring glucose should be performed more frequently when adding or modifying therapy. 2-hour postprandial glucose testing is useful in patients adhering to treatment regimen but unable to reach A1C target goals. Fasting self-monitoring of blood glucose is useful for titration of basal insulin dose. The role of self-monitoring blood glucose in stable, diet-treated patients with type 2 diabetes is not known. The goals of monitoring will usually dictate the frequency of checking that will be needed. If a patient accepts the rationale for monitoring program, then he or she will be much more likely to perform the required checks. Key considerations for designing a monitoring program include the need to obtain information about the patient's underlying pathophysiology through interpretation of daily glucose patterns, the importance of gauging the efficacy of diabetes treatment, the role of feedback to the patient in impacting self-management decisions, the degree of willingness or ability of a patient to perform checks, including physical limitations, cost considerations, personal schedule or tolerance for discomfort, and safety while performing certain tasks, such as driving. In order to interpret patterns of blood glucose levels, it is important for the patient to keep a record of the various factors that can influence glucose levels, such as variations in food consumption, activity level, and timing variations. For this reason, many patients who successfully interpret their glucose patterns from conventional glucose monitoring utilize a well-formatted record log. While computerized meters and memories can be very useful tools that can track and target trends and patterns, typing those trends and glucose patterns into the variations in daily events can be crucial to a correct interpretation of the monitoring results. It is important to advise your patients to keep a logbook. A log should include a space to record pre- and postprandial values, as well as middle-of-the-night results and other times of significance. You should be able to read across a row to see a number of values for various times on a given day. You should also be able to scan down a column to see the values for a particular time of day for a number of days running. A separate section should be used to record insulin doses or other medication. A comment section should be available to record significant variations in the crucial factors that affect control. However, one might also note items like bowling night or stressful day at the office, as these factors might affect diabetes control as well. Some people can prick themselves freehand, while most now prefer using one of various finger pricking devices that hold the lancet and, via a spring mechanism, pierce the skin. Many of the devices come equipped with various guards or platforms which can be used to adjust the depth to which the lancet enters the fingers. The lancing device is used to obtain a drop of blood. The finger is the usual source. The skin is pierced to one side of the fingertip, which has fewer nerve endings and thus is not as painful as the center. The drop of blood is transferred to the test strip, which usually contains chemicals involved in the testing methodology. The meter senses the effect of the reaction of the glucose in the blood droplet with the chemicals on the strip and produces a reading. Teaching points you want to make sure your patient receives is that they need to get an adequate blood sample to make sure their hands are warm. Dry hands thoroughly before testing so as not to contaminate the blood sample. Stick the side of the finger to minimize pain. Use a new lancet every time. Clean finger thoroughly with rubbing alcohol or wash your hands with warm soap and water prior to performing the stick. And rotate fingers Do not use the same finger for every stick to minimize bruising and soreness. Pattern management is a comprehensive approach to managing glucose levels by interpreting blood glucose trends. It allows for a more comprehensive assessment and management of medications, nutrition, psychosocial issues, and exercise. It is dependent upon records provided by the patient, and the accuracy of the records is extremely important. Before meal testing trends can be used to monitor basal corrective insulin doses. After meal trends can be used to determine the effectiveness of medications and diet. Fasting blood glucoses can be used to investigate the Dawn phenomenon or Somogyi effect. This slide provides an example of pattern management. In this example, fasting blood sugar tests before breakfast are within ADA target parameters. Tests before lunch and supper are also within ADA target parameters. However, for 3 days in a row, test results before bed are much higher than they should be. Knowing a little bit about how Novolog and Lantus work will help solve this problem. Novolog, a rapid-acting insulin, or Humalog, starts to work 5 to 15 minutes after a shot and lasts 3 to 4 hours. Lantus is a long-acting insulin that begins to work at about 1 to 2 hours after it is injected and continues working in the body for 20 to 24 hours. Eating a large amount of carbohydrate at dinner or not taking enough fast-acting insulin before dinner could be causing a spike in the bedtime blood sugar 4 hours later. A possible solution to this problem is to look at how much carbohydrate the patient is eating at dinner and consider eating less carbohydrate at that meal, or take an extra unit of fast-acting insulin to cover the extra carbohydrate. In example 2, the blood sugar in this example is close to the ADA target parameter most mornings, except for when the patient had pizza or pie and ice cream at dinner the night before. On those mornings, the blood sugar was higher. The blood sugar was also higher before going to bed the night the patient had pie and ice cream. What does this pattern show? This pattern shows that when the patient makes good food choices, the blood sugar stays close to target. When the patient eats high-calorie foods, or foods that are very high in fat, the blood sugar is too high. What is the possible solution? To avoid high sugar in the morning, the patient can stop eating high-calorie foods such as pizza, pie, and ice cream, can try eating these foods but in smaller amounts, or can try exercise after eating these foods to burn off the extra calories. High-fat foods can delay the absorption of carbohydrate, thus causing hyperglycemia much later than diets that are not high in fat. My suggestion for this patient would be to change the types of foods they eat and to choose more foods that are lower in fat. When evaluating patients for self-monitoring blood glucose, it is important to evaluate several things that could cause issues with their blood sugar results. User error is the most common of unreliable blood glucose results. This often occurs when the patient does not put an adequate amount of blood on the test strip or understands how to properly place blood on the strip. Inadequate or contaminated blood sample is also a common cause of unreliable results and errors in subsequent treatment decisions. It is important not to allow contamination of the blood sample by soap and water or other sanitizers. Test strips should be stored at room temperature, and the container must remain closed after use to avoid damaging the strip. Control solution can be used to test the test strip and meter for reliability. However, control solution also can expire. Battery life is dependent on the meter and how often it is used. Replacement batteries can be obtained from most pharmacies. Home glucose meters will not read blood glucoses greater than 5 to 600. The screen will read high in these instances. The patient should be instructed on what to do when their meter will not read their glucose result. Most meters are approved for alternate site testing. Alternate site testing means using a part of the body other than the fingertip to obtain blood or for blood sugar testing. Some studies show that the accuracy of routine testing before meals and 2 or more hours after meals from alternate sites is equivalent to the fingertips. Alternate site testing must be performed with a meter that is approved for alternate site testing. The individual needs to know when it is not safe to use this method. Alternate site testing should not be used during hypoglycemic or severe hyperglycemic events because the blood glucose arrives faster in the fingertips than in the arms. Glucoses that are falling rapidly or rising rapidly are likely to be less accurate using alternate site testing. Therefore, the fingertips should be used for non-routine testing. Most glucose meters are approved for alternate site testing of the palm and the forearm. It is important for healthcare clinicians to evaluate a patient's monitoring technique, accuracy of equipment, and interpretation of the data. Teach your patient to use the data to adjust food intake, exercise, and pharmacologic therapy. Patients need ongoing instruction and evaluation of their technique, their results, and the ability to use their data to adjust their therapy. Some pearls for practice when assessing a patient's self-management needs include what information is really needed for the healthcare provider to design and modify the treatment program, for the patient to use as feedback on his or her healthcare routine, and as an alert of potential acute problems. Another question to ask yourself is, does the patient have any physical or mental limitation that may affect checking ability or methods such as visual limitations or dexterity issues? Are there economic, social, scheduling, or work/school-related obstacles? What is the patient's professed willingness to test? How successful has the patient been in the past? How realistic is the schedule designed so that the patient can self-manage and use the information obtained? Has or will the patient receive proper teaching? Does the patient know their target values? Let's move on now to A1C testing. A1C test measures the binding of glucose molecules to amino acids in hemoglobin and serves as a record for average blood glucose levels over the lifetime of the red blood cell. As the concentration of glucose in the blood increases, the percentage of hemoglobin that turns into hemoglobin A1C increases. For example, an A1C of 7% represents the percent of hemoglobin molecules that have been glycosylated. Red blood cells live for about 120 days, after which time they die and are removed from the circulation. New red blood cells are manufactured to replace them. Therefore, the average given age of a red blood cell at any given time is about 2 months. Glycosylation occurs continually throughout the lifespan. The higher the glucose level, the more glycosylation will occur. The Diabetes Control and Complications Trials uses A1C as a primary predictor of complications such as blindness, kidney disease, and nerve damage. Keeping the A1C closer to normal reduces the risk of diabetes-related complications. As A1C increases, so does the risk of complications. ADA recommended goal is less than 7%. However, higher goals may be appropriate for patients at high risk of hypoglycemia, such as young children and the elderly. Simple blood tests performed in a lab. It is a simple blood test performed in a lab and is relatively inexpensive. It should be used in conjunction with self-monitoring blood glucose to get a better overall picture of control. There are many benefits to A1C testing. It helps healthcare providers and their patients know if diabetes treatment plan is working or if adjustments to the treatment are needed. It also can help with meter accuracy. The estimated average glucose can be compared with meter results to obtain an idea about meter accuracy. However, it should not be used as the sole method of investigation. Patients' reported results may not be a true indication of their level of control, and an A1C may also help clarify this situation. It may help determine changes needed to monitoring schedule and to be used as a tool to determine if the patient is within glucose target goals. Many studies have correlated the A1C level with the risk of developing complications. Many of these complications may even result from the glycosylation of various tissues of the body in a manner similar to the glycosylation of hemoglobin. The glycosylation of hemoglobin may represent a surrogate of what is occurring to other tissues, and the measurement of glycohemoglobin may actually measure one of the processes that leads to the complications of diabetes. Results from A1C tests are reported in percentage points. When people with diabetes test blood glucose through daily self-monitoring, those results are reported in milligrams per deciliter. They represent the level of blood glucose at that moment in time. For patients in whom the A1C and measured blood glucose appear discrepant, clinicians should consider the possibilities of hemoglobinopathy or altered red blood cell turnover, and the options of more frequent and/or different timing of self-monitoring blood glucose or use of a continuous glucose monitor. Other measures of chronic glycemia, such as fructosamine, are available, but their linkage to average glucose and their prognostic significance are not as clear as is the case for A1C. The A1C-derived average glucose study is an international study conducted in response to the introduction of a new worldwide method of standardization of the A1C assay. The purpose of this study was to define the mathematical relationship between A1C and estimated average glucose and determine if A1C could be reliably reported as an estimated average glucose, which would be in the same units as daily self-monitoring. The study established what has long been assumed, which is that an A1C does represent average glucose over time. A calculator for converting A1C results into estimated average glucose in either milligrams per deciliter or millimoles per liter is available at the web address listed on the slide. A1C testing should be performed routinely in all patients with diabetes at initial assessment and then as part of continuing care. It depends on the clinical situation, treatment regimen used, and clinician judgment. Let's do it again. A1C testing should be performed routinely in all patients with diabetes at initial assessment and then as part of continuing care. The frequency of A1C testing depends on the clinical situation, treatment regimen used, and clinician judgment. If the patient is meeting treatment goals, test at least 2 times a year. If the patient is not meeting treatment goals and/or therapy changes, test quarterly. Test when needed for timely decisions on when to change therapy. Point of care testing for A1C is considered a reliable method of A1C testing. The A1C test is subject to certain limitations that affect the reliability of the result. Conditions that affect erythrocyte turnover and hemoglobin variance must be considered, particularly when the A1C result does not correlate with the patient's clinical situation. People with unusual hemoglobin molecules, such as those with sickle cell anemia, may have invalid test results. It may also be an error in early stages of pregnancy because the fetus produces its own red blood cells. Also, be alert to patients who have recently had transfusions, as some of the hemoglobin that is being measured has not been in them for the prerequisite period of time. Anemias can render the glycohemoglobin measurement inaccurate, as well as the average age of a red blood cell is usually younger when some cause for premature red cell removal is present. Anything that causes red cells to live longer, such as splenectomy, can also affect hemoglobin A1C measurement. Another limitation of A1C is that it does not provide a measure of glycemic variability or hypoglycemia. For patients prone to glycemic variability, glycemic control is best judged by the combination of results of self-monitoring of blood glucose testing and the A1C. People with diabetes can adjust their insulin on the basis of their A1. Okay, let's do this slide again. Oh my gosh. The A1C test is subject to certain limitations that affect the reliability of the result. Conditions that affect erythrocyte turnover variance must be considered, particularly when the A1C does not correlate with the patient's clinical situation. People with unusual hemoglobin molecules, such as those with sickle cell anemia, may also have invalid test results. It may also be an error in early stages of pregnancy because the fetus produces its own red blood cells. Also be alert to patients who have recently had transfusions, as some of the hemoglobin that is being measured has not been in them for the prerequisite period of time. Anemias can render the glycohemoglobin measurement inaccurate, as well as the average age of a red blood cell is usually younger than some cause for premature red cell removal is present. Anything that causes red cells to live longer, such as splenectomy, can also affect hemoglobin A1C measurement. Another limitation of A1C is that it does not provide a measure of glycemic variability or hypoglycemia. For patients prone to glycemic variability, glycemic control is best judged by the combination of results of self-monitoring of blood glucose and A1C. People with diabetes cannot adjust their insulin on the basis of their A1C tests. That's why blood glucose testing and log results are also important to staying in good control. The A1C test alone is not enough to measure blood glucose control, but it is a good resource to use along with daily blood glucose checks to work for the best possible control. The ADA recommends an A1C goal of less than 7% to decrease risk of micro and macrovascular complications. An A1C of less than 7% is a reasonable goal for most adults. An A1C of less than 6.5% may be appropriate if it can be achieved with no significant hypoglycemia or adverse effects. Appropriate patients for an A1C of less than 6.5 may include patients with a short duration of diabetes, long life expectancy, and no significant cardiovascular disease risk. An A1C of less than 8% may be appropriate for those with a history of severe hypoglycemia, limited life expectancy, advanced micro and macrovascular complications, excessive comorbid conditions, or those with a long history of diabetes with difficult to attain goals despite compliance with self-monitoring blood glucose, diabetes medication, diet, and physical activity. Now let's talk about continuous glucose monitoring. Continuous glucose monitoring is useful to lower A1C in selected adults, usually greater than 25 years, with type 1 diabetes. Evidence for A1C lowering is less strong in children, teens, and younger adults. Success correlates with adherence to ongoing use of the device. It is a supplemental tool to self-monitoring blood glucose in those with hypoglycemia unawareness and/or frequent hypoglycemic episodes. Continuous glucose monitoring measures interstitial glucose in real time. Interstitial glucose correlates well with plasma glucose. However, it does not replace the need for self-monitoring blood glucose. Self-monitoring of blood glucose is needed to calibrate the sensors and to make acute treatment decisions. Continuous glucose monitoring devices alarm for hyperglycemic and hypoglycemic events. Alarm parameters are individualized based on the patient's needs. CGM use is associated with A1C lowering by approximately 0.26%. It is the greatest predictor of A1C lowering is the frequency of use. There is no significant difference in frequency or severity of hypoglycemic events associated with the use of a continuous glucose monitor. That concludes this portion of the presentation. If you have questions, please send me an email or post in a discussion board, and I will get back with you as soon as possible. Thank you.